Good day, my dear postgraduate students. Welcome to the topic Interpretation of Duodenal Biopsy. My idea is not directly to take you to duodenum, but also to show you the way of interpretation of biopsies, which is common for us. Yesterday is but today's memory, and tomorrow is today's dream. Khalil Gibran, and I am a fan of him. And look at the art that he himself has drawn, and very learned person whom you are seeing over here. There has to be some amount of deliberation. And that is what I am showing here. Deliberation means you will have to go point by point, commit, and then write what you are committing on. So this is the normal histology showing the tall villi over here, and there are the crypts below the surface. There is a submucosal gland and the Brunner's gland. These vary according to the duodenum, jejunum, and the ileum. The muscularis and the serosa are more or less constant. Why is the duodenum important? Because the number of biopsies have increased for varying conditions. Secondly, the evaluation of it, a pattern has to be drawn. Thirdly, there has to be an algorithmic approach. Otherwise, we'll be missing points. And this is the development. It is a tubular structure. There is a foregut from which the duodenum develops. And I find that it undergoes a rotation and you get a C-shaped structure. What it happens to it, we shall be seeing. And these are all the developmental landmarks that you people will have to go through. Initially, the epithelium is stratified columnar, but later on it becomes a single layered. It snugly surrounds the pancreas, as you see people see over here, and the great vessels behind. And this is exactly the histology. I'm finding the tall villi and then the crypts below the surface. Of course, you find that there can be the columnar cells and there can be occasional interruption by the goblet cells, which we shall be seeing. The small intestine, as such, a scanning electron microscope, thanks to this author, I am finding the villi and the muscular layer as well. There are the four layers in the GAT, all of us know the mucosa, submucosa, muscularis, and the serosa merging into the peritoneum. But these two tend to vary, whereas the others are constant throughout. A beautiful diagram from ResearchGate showing the structure of the villus. This kind of diagrams you people shall and will draw, showing a single layer that I had been mentioning. And then this is the lamina propria that you are seeing. And look at the varied height of the villi also. A beautiful picture again. I am finding predominantly the tall columnar cells, but then it is interrupted at regular intervals by the goblet cells. And in this case, there is the increased clear cells or the Brunner's glands. The lamina propria will be having the lymphocytes and the plasma cells, as you are seeing over here. So the cells in the lamina propria are these two, along with eosinophils and macrophages, according to the conditions. Neutrophils can be seen in Helicobacter infections as well. And then there can be the herpes, the cryptococcus, mycobacterium, cytomegalovirus, etc., which we shall be seeing, the lamina propria. So that completes the normal. The lesions we shall be going into. All meanings, we know, depend on the key of interpretation. So George Eliot will teach us how to interpret the biopsies. Look at this. There is a focal gastric hyperplasia, or you can call it a metaplasia also. And this is replacing the duodenal epithelium because I am finding the Brunner's glands behind. This is one controversy always happens in the first part of the duodenum, and sometimes we are confused. Shortening of the villi, then the widening of the lamina propria, hypertrophy of the Brunner's glands, typical of chronic non-specific duodenitis. The surface epithelium, you find that there is a characteristic brush border which can be positive by the PAA stain, and the Alcian blue is used for the metaplastic cells or the goblet cells. And also you find that CD3 and intraepithelial lymphocytes can be suggestive of gluten-sensitive enteropathy. There are numerous other things which we shall be seeing. Lamina propria is shown over here. a number of conditions. Always have a list with you, a compact list. And thanks to this particular author, you can go to this reference for a beautiful text in Word. I have a long list of things that make me mad. So this is it. What do you do when you have got such a long list? Directly go to the point and the picture as such. The tropical school. So it has been founded by this person, William Hillary West, in the Caribbean. And you find that is why it is called as tropical, the West Indies. And people are affected over here, and when they are away from it, they recover. And they are treated with antibiotics. There can be an intersusception as you are seeing in this picture. The radio key is a very superb mode of reference for me, and there is a cogwheel appearance of the mucosa that is shown in this. Here again, I am finding that there is a blunting of the villi, there is a widening of the lamina propria. Crypts, of course, do not change, but the ratio of the villi to the crypt gets changed. And these are the eosinophils which can be seen. I had mentioned it in this. Eosinophils and neutrophils. Bacterial overgrowth, or you find that it can be a blind loop syndrome in which there can be a E. coli overgrowth. And see, gradually there is an increase in the number of the goblet cells, the widening of the lamina propria, and the inflammatory cells. D-xylose urine breath test can be positive in the first part of the duodenum. Whipple's disease is another one, a very famous one, a favorite one of mine. I find that the villi are of varying sizes, broadening is there, shortening is also there. And some of them are floating, as he said, because of a tangential cut. And it is pale over here. Endoscopically, I find it is not smooth, and then it has got an appearance that is called the bare skin rug appearance by Robbins himself. And the villi look at a higher magnification, you are able to see the foamy macrophages. What are the manifestations of Whipple's disease? You people should read them. Collagenous poo. An author writes a rare condition over here, the reference is given. I find that below the epithelium, there is something that acellular, like amyloid that is being deposited, which happens to be collagen. A collagenous poo, probably resulting in malabsorption. Drug-induced duodenitis. There is supposed to be a Brunner gland hyperplasia, not shown in this picture, but then there is an atrophy of the villi, and then there is a flattening. Foveolar metaplasia of the gastric mucosa is seen in this region. Secondary duodenitis. It can be drug-induced, or it can be because of a number of reasons which are mentioned here. Go through these repeatedly. The same features, you find that there is a flattening, there is an infiltration, increase in the goblet cells, etc. Chronic non-specific duodenitis. There are only interpretations, no facts. So we shall start interpreting them again. A eosinophilic duodenitis. Obviously, in the lamina propria, we are able to identify the eosinophils. The cause can be primary or secondary or drug-induced parasitic infestation, rarely malignancy. And then there can be a hypereosinophilic syndrome. This is another reference, kindly go through it. The lymphoma, galtoma, maltoma, etc., or the extranodal lymphomas are all questions for us. But in this one, I am finding that it looks almost like a follicle for me, but then there is no differentiation between the central and the peripheral region. The entire so-called follicle has been replaced by a lymphoma, courtesy Hopkins Clinical Pathology. Crohn's disease is another one where the duodenum is also being affected. You can mention the classical histological feature. This is a mode of obtaining the sample. Infectious duodenitis, there are quite a number of conditions. This is GRDS, thanks to Wikimedia. I find that there is a organism that is seen in the lumen or in the surface. And this again, the Helicobacter, again, this is also seen in the surface, but much smaller. It can be rod-shaped or S-shaped. Intraepithelial lymphomatosis. So this is again a technical one. I am finding the lymphocytes not only in the lamina propria, but also in the epithelial cells, intraepithelial lymphocytes. This is a normal number, and you find that it can be increased. Is it clear? More than 30 is called as intraepithelial lymphocytosis. There are a number of causes for it. And there's a normal germinal center that we see. Probably it is creating a dome and then there is a migration. The duodenal intraepithelial lymphomatosis. H. pylori is also one of the causes for it that has been demonstrated by this IHC or the Porthinstari Silvestri. So, microvillus inclusions. Obviously, you find atrophy is very obvious in this case, but when I go to the special stain, the PAS, I'm able to see the inclusions within the mucosa. And that is again very beautifully brought out by means of a scanning electron microscope. So these are the positive points for it. Microvillus inclusion disease. The villus atrophy. So this is a normal villus that I have shown over here. This is again normal. And look at the damage one. These kind of things you people can draw for comparison. And the conditions are all given over here. So it can be this. Courtesy ResearchGate. And look at the wonderful normal mucosa, but then it has undergone an atrophy. Gluten-Free Society has given the points for all the conditions, including gluten enteropathy. So thanks to ResearchGate, in which I am finding a lot of these eosinophils also. So clear, an inflammatory process. Now, what do I do with all these biopsies? Die with memories, not dreams. So we'll have to do something. What are the methods as such? So the main indication for the biopsy you people shall be mentioning. So these are the things. So in this one, I'm finding that there has to be an evaluation of the patient. What is the status of the iron, gluten sensitive, whether there is any neoplasia, clinical symptoms such as diarrhea, is he on drugs, and so on and so forth. So what exactly is the indication I should be having on? And the sampling modality. So this is the endoscope, the suction, etc. You people can go through it. There is not only a biopsy forceps, but also a cytology brush. So it is becoming more advanced. And how frequently you should take the biopsies? So at least 3 to 4, the details are given over here. Areas of atrophy and the areas of flexure and different histological lesions which you anticipate. And all of them should be well oriented, we shall be showing you. Like this. You find when you shave off a thing and when you embed, it has to be perpendicular so that when I cut a section, I am able to see the villi. Many of us, sometimes what we do is when there is an embedding, I find only the tips of it, the rest of the mucosa is not seen. We are unable to report on. Always have an algorithmic approach. That is one. You find that there can be some cases positive for celiac or it can be ruled out. In each of those cases, what is going to be the differential diagnosis and the modality of treatment? Because just like anemia, malabsorption also is not a disease in itself. And unless I find out the exact cause of it, I will not be able to treat. What are the stains? Again, making a list of it. The laboratory diagnosis, a very common one. As I mentioned earlier, the PAS is over here. Weight fights can be done. Tuberculosis can also be there, or the atypical organism. In this case, for instance, I put a picture of the immunoperoxidase for cytomegalovirus as a seen over here. And these are the markers again for gluten sensitive enteropathy. Neoplasia, you'll have to do required ones. The biopsy report, how do I? So on seeing the biopsy, I'll have to mention on all these things. What is the number, the site of biopsy, what is the villus site, what is the architecture, and what is the crypt, what is the ratio of the villus to the crypt, etc. Is there any hyperplasia of any one element? Is there a gastric metaplasia? Something like a CAP protocol you people should build up so that it can be reported. It is not necessarily on resected specimen. Even on biopsies, you find such a list is required for us to meticulously do the reporting. Strongyloids. Look at this one. Again, within the crypt, I am able to see the organism. Small intestine, ampulla, etc. It can be seen. And it can be in the duodenum also. Thanks to this pathology outlines author. Again, GRS. This is one person whom I very much respect, labpedia.net. Very many diseases have been very beautifully depicted in this one. The cycle of the giardia. Kindly go through it. And this is the histological picture. Sometimes these other tests can be done. What is the motion test, PCR? and then a DNA fluorescent test. Interpretation of biopsy depends on the grading of the villus atrophy. You people can go through this one, particularly the mass classification we'll have to mention. So I find that progressively there is a decrease of the villus height, and you find that the crypt as such, initially it remains constant. Therefore, I find that the villus to the crypt ratio becomes reduced, or the crypt to villus ratio becomes increased whatsoever. The same thing is mentioned over here, and I'll have to mention. The crypt hyperplasia leads to regeneration. Sometimes there can be branching of the crypts, etc., that can be seen, and an increase in length. I'll have to look for increased mitosis or use the key 67. And these can be the reasons for it. And what are all the various clinical-pathological points that you people require? Again, the history is of paramount importance. What are the other findings radiologically? I showed you the disease, the Whipple's disease, for example, and then the endoscopy. So this is a nice quote again, go through it. So this is a Marsh one. It shows you the grading of it regarding the increased intraepithelial lymphocytes, the crypt hyperplasia, villus hypertrophy. What are all the points accordingly? What is another mode of grading is given over here. This you people should mention. The celiac disease, all of us know, I'm not going to go into it. Paradoxically, it is going to be almost the same. So I find that this is the villus height, the crypt depth that is given. What are all the various cells, including the Paneth cells that you people see over here, capable of multiplying, and these are all differentiated cells. So there's a normal intestine, and in this one, I am finding the atrophied mucosa. This is a beautiful one. Hats off to this person, Priyanka Singh. In many a topic, she has brought out such a chart. I would like you people to kindly go through each one of her creations. So, how it happens to be an autoimmune disease, what are the substances that are there, what should be the mode of treatment, and how it is being caused. And after it is being caused by gluten, what is a gluten-free diet that is being given, what is the patient who is refractory, what are the other associated diseases. Any of the autoimmune disease, you find that there can be the other diseases. What is the histological finding, cancer and etc. So there's the endoscopy. These are all the things that you people see. It can be a white spot, colored visualization, or the image can be enhanced by means of this LCA. Look at the microvilli here. Classification is an aid to orderly thinking. So gluten-related diseases, infectious diseases, immunological diseases, drugs, and others. You make a list by heart and then recall the features. Remember the to-do list, but don't forget the to-be list. Thank you.